consent versus assent. And consent is the permission for something to happen or the agreement to do something. Assent, also the expression of approval or agreement. But in research, assent is a term used to express willingness to participate in research by persons who are, by definition, too young to give informed consent, or for those that lack decision-making capabilities. Those giving assent may understand the proposed research in general, its expected risk and possible benefits, and the activities expected of them as subjects, though. Assent by itself is not sufficient, however. If assent is given, then permission must be still obtained from either the subject's parents or the legal guardian or proxy. Okay. I want to go over the guidance for or the regulations that guide us in our in informed consent today. And as you remember, if you were here for Janie Garner's talk on the first session, she gave a very detailed presentation on the background of how we got to where we are today. The first major document that outlined how consent was to be done was in 1947 in the Nuremberg Code. And that was a direct result from the Nazi trials and the first time that voluntary consent was determined to be essential. In 1964, the World Medical Association gave us the Declaration of Helsinki, and the main point in this document was that consent should be obtained if at all possible, and increased vigilance is needed for vulnerable subjects. In 1979, the Belmont Report came as a result from the National Research Act, which was a result of the Tuskegee syphilis experiment. But the main principle the Belmont Report had three core principles: respect for persons, beneficence, and justice. And it clarified that the informed consent is a necessary part of showing respect for all persons. In 1981, the FDA harmonized 21 CFR 50 with OHRP 45 CFR 56, Subpart A. These codes of federal regulations outline requirements for obtaining informed consent. In 1991, the Common Rule, which is 45 CFR 46, was adopted by many of the governmental agencies, and the Common Rule is the baseline of standards of ethics by which any government-funded research in the U.S. is held. And nearly all academic institutions hold researchers to these standards regardless of the funding. And if you were around in January of 2019, you know that there was a lot surrounding the revised Common Rule. And it was pretty monumental because the regulations had not been changed or revised in 40 years. Also in 1991, the International Conference for Harmonization, Good Clinical Practice, Dorita gave a really good talk about that earlier, GCP E6 revised revision 2, stated that freely given informed consent should be obtained from every subject prior to clinical trial participation. So those are the backgrounds, but there are a lot of other documents that can lend or be a resource for help in directing us on how to give informed consent or obtain informed consent. The FDA has numerous guidance documents that can be found on their website. IRB SOPs give us direction. If you have a sponsored protocol, most of the time those will have a section in them about how informed consent will be obtained. Departmental institution policies may be available in your institution about obtaining informed consent. And then there are also state and local laws. And in Tennessee, Mississippi, and Arkansas, there are not really any clear-cut laws about obtaining informed consent for research subjects, but California definitely has some laws. And for guidance or the way you maneuver all of these regulations about informed consent is that you have to follow the most restrictive policies regarding the informed consent process. Okay, so I want to talk a bit about FDA versus OHRP. 21 Code of Federal Regulations 50 versus the Office of Human Research Protections 45 Code of Federal Regulations 46. And they're virtually identical, but FDA requires that a confidentiality statement be included in the informed consent that says specifically that there is a possibility that the FDA may inspect records. FDA also requires a statement regarding study registry in clinicaltrials.gov. And if you're not familiar with clinicaltrials.gov, it is a public registry where governmental funded research you are required to register your study if it is a clinical trial. And it's a place for transparency so that everyone can take a look and see what studies are available to the public, who is the investigator, who's the contact, inclusion and exclusion criteria, and any risk that may be associated with that clinical trial. So why is the informed consent necessary? It's an ethical requirement. It's basic for respect for persons. It ensures the subject is fully and accurately informed, and I say we hope. We don't have any guarantees after a subject undergoes the informed consent process that indeed has been fully conveyed, but we hope that that subject is fully and accurately informed. It may demonstrate comprehension of the information, and again I say may, because usually we don't give them a test. And it authenticates the decision is voluntary. It also protects the rights, safety, and well-being of subjects. So let's get back to respect for persons. And respect for persons, self-determination, autonomy, all those related to the same concept, demands that subjects enter into research voluntarily and willingly with adequate information. The principle of respect of persons divides into two separate moral requirements: the requirement to acknowledge autonomy and to protect those with diminished autonomy. Respect for persons requires that subjects, to the degree that they are capable, be given the opportunity to choose what shall or shall not happen to them. And this opportunity is provided when adequate standards for informed consent are satisfied. So the informed consent process is more than just signing that form, and I want to emphasize that completely. It's an ongoing process. It begins with recruitment materials such as flyers and ads, emails. Why is that so? Because those are usually the first introduction that a subject has when learning about an available research study that they might want to participate in. It continues with that first contact with that potential study, whether it's in the clinic or a health fair or in the hospital. It then progresses to the discussion or exchange of information or a dialogue regarding the actual consent form. There is then consideration of participation to allow time for thought, discussion with family and friends. And I want to emphasize this because when you're asking a subject to participate in a study and it's going to be quite involved, family or friends may be the persons that transport that subject to the clinic visit. They may be helping that subject collect data or record diaries or manage their medications. So it may be a family affair, not just consent of the subject. And then the last is the need for additional information or clarification, meaning always allow time for questions from that subject. So the informed consent process must occur without the possibility of coercion or undue influence. And I want to define these terms. Coercion is the practice of persuading someone to do something by using force or threats. We don't really think about that occurring with research, but I want to give some examples of how that might occur. For example, Mrs. Smith, you will not be able to obtain medical care from this clinic if you choose not to participate in this study. That's coercive language. Prisoner Jones, you will lose your canteen rights or lose your potential parole if you do not participate in a research study. So, and those sort of coercive actions are actually what resulted in the very restrictive regulations regarding prisoner participation in research, and why you have to have a prisoner representative on your IRB if you have a prisoner in your research. Undue influence, by contrast, often occurs through an offer of an excessive or inappropriate reward or other overture in order to obtain compliance. And some examples of that might be, let's say an investigator might promise psychology students extra credit if they participate in research. And if that's the only way that that student can earn extra credit, then that is undue influence. If, however, the investigator offers a comparable non-research alternative, then possibility of that undue influence is minimized. And I've seen this occur over and over when I was with the IRB. And we would always ask that investigator offer an alternative, such as a student may do a report or a alternate project that would gain the same amount of extra credit as participating in the research. Another example is somewhat subtle. So a subject, if they're approached by their physician or to participate in research, might feel undue influence to be a part of that research, or students might feel pressure to participate if everyone else in the class is doing so. So I pulled this from the web, and I thought this is really an interesting policy from the University of California, Santa Barbara, on what they can and can't do for patients or employees or students. And I'm just going to kind of highlight the gist of this. A subject's participation in research must be completely voluntary. Great care should be taken by investigators to avoid even the appearance of coercion or undue influence when recruiting potential study subjects. For this reason, the Human Subjects Committee at University of California, Santa Barbara requires that review and approval of all subject recruitment materials happen so as not to downplay serious risk, give the impression that participation is mandatory, or emphasize financial inducements. Also, to reduce the potential for real and apparent coercion of study subjects, UCSB discourages investigators from direct solicitation of students in their own classes or employees in their own department. And I know at UT we don't have any such rule. And when we go back to their policy at UCSB, an investigator may recruit students or personnel from their department with general recruitment advertisements, such as a poster hanging in a lounge, or additional safeguards protecting subjects from actual or perceived coercion must be added to the protocol. So I thought that was a very interesting perspective on protection of human subjects from undue influence or coercion. So let's continue on with the informed consent process. The informed consent does not end with the signing of the documents. Nope, you're not finished then. At each visit, the following should occur and be documented. Assessment that the subject understands what's being asked of him or her in the subsequent visit. In other words, a person comes back for their third visit. If they're getting a blood draw, CT scan, whatever the visit entails, then you should be going over that briefly to make sure that they still want to participate. The subject has an opportunity to ask questions and answer to their satisfaction, and you need to verify that that subject truly wants to continue participation in that study. And I know of some studies that the long-term longitudinal studies, subjects may be involved for 18 to 20 years, especially in some of these long-term diabetes observational studies. And yes, with every visit, you need to go over these principles again. Do you still want to participate? So who can obtain the informed consent? The person obtaining consent must be qualified, of course, by education, training, or experience. Principal investigator always can obtain informed consent, but others that may be on the study team should be listed as key study personnel on the IRB application as being able to obtain informed consent. They also need to be placed on that delegation of authority log by the PI for this task. We need to make sure that their city, and that's just a platform, and I'm not sure if everybody uses city platform for their human subjects protection, good clinical practice training, but whatever your institution uses for human subjects protection, to make sure that everyone obtaining consent has that. Protocol training and documentation of that training. Dorita did a really good job on talking about that last time. And adequate medical knowledge or understanding of the protocol, why, and the investigational product is because the person obtaining consent has to make sure that they're capable of answering any questions that the subject may have during the informed consent process. And of course, good communication skills. So where should the ICP be conducted? And the setting should be quiet, comfortable, and private. And I'm going to emphasize comfortable and private. And the informed consent process could happen in a hospital room, in a clinic, but I also know that they have occurred at health fairs. And one particular study that was submitted to the IRB was one at a convention where they were looking at it was a convention where prosthesis for loss of limbs was going on. And my question, particularly to that investigator, was how are you going to maintain confidentiality, or is there going to be a room where you can actually obtain consent where it's quiet, comfortable, and private? And yeah, assured me and the IRB that that would occur. So when should the ICP actually be conducted? And it's got to be before initiating any specific procedures, and this includes washout periods. And for those of you who are not familiar with a washout period, that could be any time before actually starting the actual research project. It may be a period where you've asked the research subject to fill out a diary. Maybe that's part of the study procedures, and you need to make sure that they are going to be compliant with completing that diary. It may be a washout period where a medication is eliminated that might cloud the data collection during the research study. So anything that is study related, that informed consent has to be done prior. And in my experience, I know that a research assistant actually lost their job over this because we had in one of the studies that I managed, patients or subjects came in fasting, and that particular research assistant took the subject to get their lab drawn before obtaining informed consent. And I understand the subject was hungry, but I want to emphasize that wasn't the only thing that research assistant did. But it's very important to make sure you have consent before you do anything. Every subject contact is an opportunity to reiterate or reinforce information and ensure that that subject continues to be fully informed and is voluntarily participating. Can't emphasize that enough. And then you should always reconsent if there's something that has changed in the protocol, if there's something or new information that we know about the study itself. For example, if there's new information that's come about due to an increased risk or an additional risk. Let's say another reason for reconsenting is that maybe the study has been extended. It may be going on a year now versus 6 months, where you're going to make sure that that subject still wants to participate a year from now rather than 6 months from now. So how to conduct the informed consent process. It can be actually broken down into 3 elements or 3 sections: the information that's given, comprehension, and voluntariness. So very important 3 principles. So when you actually walk into that clinic room or hospital room or wherever you're obtaining informed consent, logically you need to introduce yourself and to establish some sort of relationship with that subject. You've got to know your protocol backwards and forwards, again, to answer questions. You've got to explain the consent procedures and the actual process to the subject. You know, make sure that they know that they're going to have plenty of time to read that document and that you were willing to discuss any aspect. Make sure you explain those procedures and that they are consistent with your approved IRB process. You discuss that informed consent with your subject, allow adequate time, and then make sure that you do have adequate time for questions and answers. And I want to kind of stop here and just say, and it's happened to me on many occasions when a subject, you hand that document to a subject and they say, I'm okay with whatever you think. You can't do that in this situation. They have to read that consent form, and it may take 30 minutes. And yes, that takes a big hunk of time out of the clinic schedule that you may have, but you have to do it. You have to allow that 30 minutes or even longer for the appropriate amount of time to adequately address the informed consent. And then make sure that your subject is fully informed. You have to keep your subject in the center of the process. You have to be an active listener. You have to ask open-ended questions to make sure they understand and comprehend. And then this is very important, nonverbal messages. And if you have a subject or a child who is, okay, my screen was just lost. Tarita?
Just a minute. Yen, please quit sharing your screen, please.
Okay.
You got
There
it
we
back.
go. Sure. I think I was talking about nonverbal messages, but if you have someone in your examination room or clinic room that is obviously uncomfortable, but they're not saying that they don't want to participate, that is the message to you that this research study may not be for them. Okay, I'm still having problems, Dorita. Don't know. Okay, and then do not rush the process or make sure that they have ample time to consider participation. So this is a really important concept to me, and I don't know that it's talked about a lot, but I deal with adults with intellectual disabilities, and I know that's not the focus of our talk today, but we focus a lot on yes statement from the subject. Yes, I do want to participate. Yes, I will sign the informed consent. But it's equally important, or equally important to saying yes, is the ability of the subject to say no. Is your subject feeling pressure or undue influence? Is your subject trying to please another, like a parent, provider, or friend, by saying yes? Is your subject cognitively able to say no? And does your subject say yes but actually means no? And I know my experience with that subset of the population, cognitively impaired adults, oftentimes they do say yes to please another person and cannot really say no. Okay, make sure the language is understandable to your subject. And are you using the correct version of the ICF? Now, I know that if you all have worked with a sponsor, you know that there are multiple revisions that occur with the ICF, and sometimes it's hard to keep track of that ICF. If you use an electronic data IRB system, your most recently approved ICF will be there, but we all know that we keep a copy on our desktop. Just make sure that you stay organized and maybe trash the old consent forms that are no longer valid, because you will always have a copy of those in your electronic data system with the IRB if you're using that. Oftentimes visual aids are allowed. Sponsors are really good about giving brochures, videos, tables that show or outline what actually happens at each visit. If you use those, just make sure that they are IRB approved, but they are very helpful. So how does your...
Ms. Lynn, I'm sorry, your screen is blank. We can't see your handouts.
Hold on a minute. Margaret, what slide are you on?
Let's see. How does your consent form measure up when it comes to lay language? I'm not sure how we've lost our screen.
I'm not either, because no one else should be able to share a screen but us. Do you know what number slide? I'm so sorry.
It's 27.
Okay. Let me see if I can share mine, okay?
You can make Margaret a co-host. Dorita, I think you may be the only one that can do it. Then she can.
She already is a co-host. She was sharing her own screen.
But it says guest. You actually have sharing enabled for all users, which is why Yen was able to share their screen.
That's not
So
how it
all
was.
guest users can share their screen. But
Not,
you should make, as practice, you should make Margaret a co-host, and then you can limit so that guests can't share their screens.
she was a co-host, Lawson. We did that at the beginning. Okay, can you see it now? Lawson, can you see my slide now? I'm sharing it.
Yes, I can see it. Yeah.
Yes.
All right, I'm so sorry about that.
So I'm on 27, but I don't have any control to read it over my slides.
Just tell me and I'll advance.
Okay, so I'm on 27. How does your consent form
Okay, I got it. I got it.
How does your consent form measure up when it comes to lay language? And the federal regulations are very specific about this in 46.116, and specifically says the information that is given to the subject or the legally authorized representatives shall be in the language understandable to the subject or legally authorized representative. The National Institutes of Health recommends that the readability of patient education materials should not exceed a 6th grade reading level. And then the average reading skill of the U.S. is about 8th grade level. And here at UT, we put that restriction or guidelines on our consent forms that it has to be at 8th grade or lower reading level. And I encourage you to use in your Word document the ability to assess your reading level. Okay, next slide, please.
Done.
So this is what the consent form may look like to your subject, ancient cuneiform. Just know that if they have no medical background or ability to understand medical terminology, that it may look like hieroglyphics to them. Next slide. So some common language mistakes in an informed consent. I just want to go over some examples of this. Hi, Mrs. Smith. At today's visit, you're going to have an EKG. The electrocardiogram records from the body surface and registers the differences in electrical potential generated by the heart. The signal recorded is determined by action potentials generated by millions of individual cells in their sequence of activation. And if I'm a patient or a client or a subject, I'm going to go, what? So next slide. Let's do an instant replay on this. So let's say, hi, Mrs. Smith. At today's visit, you're going to have an EKG. The electrocardiogram EKG is a picture of electrical tracing of your heartbeat or your heart rhythm. Much easier. Okay, next slide. So another example, Mrs. Smith, the study that you would be participating in if you choose to volunteer is a multi-armed research study. Each arm of the study would receive a different dose of the study drug. So what might that subject visualize? Next slide, maybe something like this. So let's do a replay. Mrs. Smith, the study that you would be participating in if you choose to volunteer has 4 groups. Each group will receive a different dose of the study drug. Groups is a very important word rather than arms. Okay, next slide. Mr. Smith, the study that you will be participating in if you choose to volunteer is a double-blinded study. At the end of the study, you will be unblinded. Okay, next slide. So is that what they see? Maybe. So let's do a replay of that. Mr. Smith, if you choose to participate in the study, you will not know which medication group you've been assigned to, and your study doctor will not know either. This is called double-blinded study. At the end of the study, you will find out to which group you were assigned. Okay, next slide. Another example, Mrs. Smith, this trial will last for 3 years. Okay, next slide. Is this what they see? And this one is probably an example of one of the consent forms that sticks out in my mind when I worked at the IRB, and it was a sponsor who was European, and I think that they probably used the word trial over 100 times in that consent form, so it was not appropriate. Okay, next slide. So a better way to say that is, Mrs. Smith, this research study will last for 3 years. So I just want you to be aware of how you present language in your consent forms. Okay, next slide. So how do we assess understanding? We can do that by the teach-back methods. Tell me in your own words how you would describe something in the consent form. You can ask open-ended questions such as, how would you describe the purpose of the study to your family? What will happen to you in the study? What are the benefits of your participation in the study? What are the potential risks involved if you participate? And what are the alternative treatments available to you if you do not participate? Next slide. So there are some hard and fast rules that federal regulations state regarding the content of an informed consent. There are some essential elements that have to be in your informed consent form, and they are a specific statement that the study is research. You have to describe the purpose and procedures. You have to give them alternatives to participation. You have to state specifically that this is voluntary. You have to clarify which procedures are research and which are considered standard of care, because that oftentimes gets muddied in the minds of a subject. You have to define how you're going to keep the data confidential. If there are or is any compensation for injury, you have to also talk about the length of participation, risk, benefits, and discomforts, and you have to give them contact information for a contact for the study for any kind of questions that they might have. Next slide, please. So these are additional elements that can be added to your informed consent form. They're not mandated, but of course, if you need to discuss these sort of issues, you need to include them in the informed consent form. Here at UT, our consent form templates that all investigators use actually contain all of the essential and the optional elements of the informed consent. So the optional elements are, you need to discuss risk if the subject is or may become pregnant, the circumstances which the subject participation may be terminated by the PI. For example, that the subject will be terminated if they don't make their study visits or if they're not compliant with their dosage of medication, etc. You need to discuss additional costs to the subject, any kind of new findings that may affect willingness to participate, approximate number of subjects. And this one's really pretty important because many times subjects want to know if they are one of 10 people participating in the study or one of 2,000. And then the consequences of subject's decision to withdraw. For example, if that subject decides to withdraw, then study staff needs to ask their permission, possibly, if they or is the subject willing to come back for a final examination? Are they willing to allow data collection from their medical record, even if they don't want to come back for visits, things like that. Next slide. So some of the barriers that occur when conducting the informed consent process are pretty logical. What's the cognition capacity of the subject, their level of education, social or cultural values, and in some parts of the world it is actually offensive for you to ask a subject to sign the consent form, because that denotes that you mistrust their verbal agreement. But here in the United States, that consent form has to be signed. Language barriers. And that's a whole other discussion for another time, an advanced course on informed consent about what to do if English is not the primary language of that subject. Age, the environment, if they have anxiety or fears, readability, we've already talked about that, and of course the length of the ICF. I have seen perfectly adequate consent forms that are only 4 pages long, but then I've seen 35-page consent forms for a pretty intense oncology protocol. So next slide, please. So what's needed after obtaining consent? The original consent form is to be maintained with research documents unless you have an approval otherwise by your IRB. You are supposed to give a copy to the subject, and if you are not restricted by, or you don't have to follow ICH GCP, you can hand a copy of the consent form to the subject that is not signed, in other words, a blank copy. But if you are following ICH GCP, you need to give a signed copy to your subject. So, get the consent form signed while they're doing their other clinic activities. You'll have to go get a copy and then bring them a copy back at the end. Completion of the ICP documentation. We're going to talk about that later in just a minute. You have to document and place a copy of the ICF in the subject's medical record if that's a requirement by your institution. You have to document continued desire to participate at each subsequent study visit. You have to do that. You have to reconsent if needed, and remember, it's an ongoing process. Okay, next slide. So what is this business about documenting how the informed consent process went? Yes, in your research record, you have to have a paragraph. I'm going to show you a template in just a minute about how that actually occurred. But here's some items that need to be included in that statement. Was there sufficient opportunity to consider participation from the subject? Did you give them ample time and opportunity to ask questions? Was the ICP conducted without coercion or undue influence? Did the subject say they understood the procedure's risk and benefits? And the ICF was signed and dated before any study procedures were performed. So that's the basis of what needs to be in your documentation of the informed consent process. So here, next slide, is actually an example of what UT uses for guidance for helping their investigators know what to chart in their research record. And it's kind of wordy, but basically it's subject name, the protocol, the IRB number, that the subject was given the information, they were given adequate time to read, it was signed at a certain time, and then the language of the subject and whether or not a translator was present or not. So I'll be happy to send this to anyone if they want to email me at mlyn@uthsc.edu. Next slide, please. So, the end, audit findings. Do we really want to talk about that? Of course we do. What are some of the things that are found on an audit associated with the informed consent process. The use of incorrect informed consent or an expired informed consent. And that's why you've got to have a really good document control so that you always have the most currently approved informed consent to use. Research team completing dates or times for subject. I've been guilty of that. You know, you're in a hurry, so you go ahead and put the date and time. But I think of recent years, auditors, whether they are the monitors, FDA, wants to see those dates and times written in the subject's own handwriting. The next thing is missing signatures or omission of initials on each page, and our IRB requires that an initial is at the bottom of every page of that consent form. The next thing is subjects were not reconsented when there was a need for reconsent. Incomplete or incorrect dates and times, and then check boxes within the consent are incomplete. And what this actually means is that oftentimes a consent form will have a box well, the offer will be extended to the subject whether they would like to participate like in a sub-study or additional data collection, things like that. And so there may be an initial box embedded within the consent form that the subject is supposed to initial. Okay, next slide, please. Next slide, yeah. Okay. So some other things are corrections don't follow the slide rule, and that's where if you have an error, everybody makes errors, so you strike in a single line, you initial, date it, explain the correction or put the correct data point in that document, and then the use of whiteout is an absolute no-no. Sometimes investigators per policy of their institution are required to sign within 72 hours, and if this is the policy and they don't do it, then that will be an audit finding. The documentation of how that informed consent process was not found, and then the person obtaining the consent was not qualified. In other words, they were not listed on the delegation of authority log or not on the IRB application. Okay, next slide, please. So what do you need to do if this occurs? Retraining. That may be what has to happen. Maybe you use the buddy system to check for errors, and how that would work is the research staff member obtains consent, then they go on along with the subject to finish their clinic visit. They may hand off that consent form to their buddy for a second set of eyes to check to make sure everything's there. Then at the end, the second pair of eyes may come back to that research assistant and let them know if there have been any errors so that they can be corrected before that subject leaves the facility. Because once they leave, it's hard to get those items corrected. It may be the next visit before that can occur. So if that happens, you can put a memo or a note to the file, and it may be a typewritten note, it may be on a sticky note. You just need to make something in that research record that says, yes, we are aware that Jane Doe did not initial page 4 of the consent form, but we intend to have them initial on their next visit. You need to report to the IRB any kinds of errors per their policies. Oftentimes, minor things like not initialing are not considered a deviation. You just need to check with your IRB. You may want to do some internal audits. Just check a percentage of the charts that you have or research records and see how you're doing in that area. And then there's also corrective and preventive actions that you may want to develop to prevent those errors. Next slide, please. So in summary, do it right. Just remember to follow the regulations, guidance, or SOPs for obtaining consent. The informed consent process is conducted to protect rights, safety, and well-being of the subjects. The goal is to ensure that the subject is fully informed and has a good understanding of the research procedures. Be proactive. If you need to construct a corrective action plan, do it. The process is ongoing, and take your time and do it right. And then in summary, or at the very end, I wanted to share this quote: "No man is good enough to govern another man without the other's consent." Abraham Lincoln, a very smart man. So, Dorita, do we have any questions?
No, not at this time. And I apologize for the technical difficulties. We'll have this re-recorded and have it up on our website with the rest of the presentations. Thank you, Margaret, for presenting today. It was very informative. And I know everyone that's involved with research needed to know the information that you presented today, and we thank you.
Thank you.
Our next class is this Thursday at 11:30. And myself and Carol Hendricks, who is the research nurse manager for the Biorepository and Genomics Initiative at Le Bonheur Children's Hospital, will be presenting on regulatory and essential documents and the record keeping of those documents. So we hope you join us next week. And thank you so much. We appreciate y'all attending.